headline figures, there were things happening. But put it into context of the sort of data I was presenting for stroke units and early discharge, the potential impact in terms of extra independent survivors was relatively small. And you're probably talking about 1 or 2 extra independent survivors for every 100 people treated. And that applied to both the, if you like, the ADL focused service and the, it's going to come up, stroke liaison worker type service. They both showed a relatively modest impact when we looked at the, if you like, the impact on a very headline outcome like living at home and independent. So what I would be arguing, if we were going from the evidence, is that there are certainly 3 service models that we should really be seriously thinking about, or at least should be our first 3 priorities. I would argue the stroke unit would be the first one, because I think there's all sorts of benefits from having a stroke unit. And it's, I'll show you shortly, it's one of the biggest impact interventions. But there are the early supported discharge and the rapid neurovascular service both appear to have a tangible, real benefit in terms of population health. However, certainly in the UK, things are changing very fast in a rather, not a surprising way, but I think the pace of change has rather surprised me. And there's a much bigger emphasis, very suddenly, on acute stroke management. And the place you particularly see this is in London. Now this rather busy slide is a diagram of the proposed stroke new stroke pathway in London. And Greater London's got a population of about 8 million people. And what they're proposing is to centralise, or they've started doing, is centralising stroke services in about 8 hospitals. So it would mean, for instance, for Tasmania, you would have 1 hospital doing stroke. In fact, you would have half a hospital doing stroke. And what they've really built this around is essentially an untested model of care, which I've circulated there, which is the hyperacute stroke unit. And the idea is that most people are funneled through this hyperacute unit, but you only spend about 24 or 48 hours there, and then you're repatriated, I think is the term, to wherever you came from. And that you should access the other services going through that process. But why has this change happened? Well, I think the biggest driver is thrombolysis with tissue plasminogen activator. And the diagram there just shows an angiogram where somebody's vessels opened up with TPA. And there is a reasonable amount of evidence now for TPA. This is a diagram that everyone shows at acute stroke meetings, and it shows the benefit of being treated with TPA in acute ischemic stroke, and the benefits on the vertical axis, and the time from stroke onset to treatment is on the horizontal axis. And the solid black line is the odds of making a complete recovery. So as you can see, the black line starts off high, where people have maybe a 2.5 times increased chance of making a complete recovery if they're treated at 60 minutes, and then that gradually declines as the time delay gets longer. It's the time is brain story. And the first clinical trial to demonstrate this was the NIND study, as an American one, which managed to treat most people within about an hour and a half, and they got really a very significant benefit. And on that basis, the treatment license was provided. There's been a second positive study, which will come up in a moment, and it was called ECAS-3, and they extended the time limit to 4.5 hours. But although they got a significant result, you can see the actual benefit is much less. And if you put this into the kind of numbers I was showing you earlier, if you treat people very quickly, the potential benefit is enormous. For every 100 people, acute ischemic stroke people who are appropriate for this treatment, for every 100 treated quickly, you might get 29 or 30 extra independent survivors. But if you delay it, you're right down to a much more modest result. And if you delay it even further, you start to kill people. It's dangerous. So there's a real imperative to do this as quickly as possible, and also as accurately as possible. Do it, get it to the right people and very quickly. There's been other arguments that I've heard made. One of them is to allow people to access very sophisticated imaging, and there's all sorts of imaging techniques now. I think it's worthwhile remembering, though, that this might be important in the future. It's certainly important for research, but almost all of the evidence I've presented so far is based on people having a plain CT scan, which is available, I think, in probably all of the hospital sites that we're connected to. I think most of them. So we certainly don't, this sophisticated imaging is not essential at the present time. Another argument has been that we should centralize things so that we can get neurosurgical interventions. And I know David was just telling me that the Neurosurgical Centre for Tasmania is here in the Royal. And there is some important works being done. The top pair of slides is of somebody who had a decompressive hemicraniectomy. Basically, this is a syndrome in young, particularly young stroke patients who have a massive stroke and at risk of dying from intracerebral swelling. And it's been shown that there's been 3 clinical trials, and if you operate and decompress this, you can certainly allow people to survive, and a proportion will get back walking again. It's still a very disabling scenario, but it is certainly a life-saving treatment. And similarly, there's some work done on primary intracerebral hemorrhage, that there's some groups of intracerebral hemorrhage people who benefit from neurosurgery. But again, most of these operations need to be done within 24 hours, 48 hours, not necessarily within 1 or 2 hours. So you certainly need your regional centres, but you don't, and you need rapid referral, but you don't necessarily need everyone going straight to the neurosurgical centre. Another argument is it allows us to do more carotid endarterectomy more quickly, and certainly there's, for people who need carotid surgery, the earlier you do it, the better. The the graph I've just shown you there shows a breakdown of the benefit. The histogram columns are how much benefit you get from getting your carotid arteries done, and the horizontal axis shows the number of weeks from having your symptoms to getting the operation. And you can see the benefit is definitely there in doing it early, but you're talking in a couple of weeks, and most services can get operations done that quickly. So it's not something, again, you don't have to move everyone to one centre to get acutely to get this done. Some people have argued that you need these big hyperacute centres for doing other things. Carotid angioplasty is another new technique as an alternative to carotid surgery, but I think I've followed this story with interest because, I'm sorry the graph hasn't projected very well, but basically there have been 4 big clinical trials here, and the old-fashioned, the 50-year-old carotid operation is consistently better than the new toys with carotid angioplasty and stenting. So I don't think having fancy angioplasty suites isn't really an argument for stroke at present. And another driver, which is particularly the case in the United States, is the very new approaches of clot removal. The top one shows the sort of corkscrew approach, mechanical clot retrieval, and the bottom one is an intra-arterial thrombolysis. Instead of giving someone an injection in the vein, they put the catheter right up in and give it directly to the blood clot. And in some hospitals in the States, I'm told that if you turn up in casualty with a suspected stroke, you'll be into the angiogram suite within minutes, and somebody will put a catheter up to try and remove the clot. And ironically, what happens after that is you then see the neurologist to see if it was a stroke in the first place. So I think that some of these hospitals have got the services a bit back to front. But the bottom line is there are no randomized trials or no substantial evidence that these approaches are beneficial. And what the enthusiasts forget is that there are delays in getting these things set up when somebody arrives at hospital, and you lose time, and time is brain. So I think this is something for the future, but it's not a current reality. And some of the ways that stroke services seem to be going in the UK remind me what happened with acute MI. This graph shows the case fatality, the death rate in acute MI in Scotland, and basically the pattern of service provision, where we've moved from having stroke patients in general medical wards to coronary care units, and now we have big regional centres where all the acute MI people go to. And in many ways it's a kind of the move from an old-fashioned general medical era to a kind of super drug era, thrombolysis, and then to this sort of super tube era where they've got primary angioplasty. And in some ways I think we're seeing that kind of pressure and that kind of change with stroke.